Vishnu sir, you can stop sharing your screen, sir.
I have already done my work.
Yes, but your screen is reflecting here still.
Yeah, I'll unshare the slide.
Yeah. So next class is by Chinmayie ma'am.
Padma, I've connected. I'll just share it. Shall I share?
Yes, ma'am.
Hello.
Happy afternoon, ma'am.
Yeah. Happy afternoon.
Yes, ma'am. It's yes.
Visible, na?
Yes, ma'am.
Yeah. Yes. Happy afternoon, everybody. So today we'll be discussing on two important instruments that will be used in reproductive medicine. One is the OPU needle and the other one is the embryo transfer catheter. So it is not just a procedure. You should know about the instruments also in detail so that you will be able to decide what is best for what, or if there is any problem, how do you tackle it, what are the problems that you can encounter during the procedure. All those things you will come to know through this procedure in this class. Okay, and if you guys have any doubts, you can always stop in between and ask. So before proceeding with the OPU, whenever the trigger, everything's been decided, there are certain checklists that you should keep it ready in the OT, or certain things that you should be prepared for when you're planning for embryo transfer. So when you're planning for oocyte pickup, what is that? One is the OPU needle, whether all the tubings for the suction and all is ready. Suction pump, whether it is working properly. Do you have the sufficient Falcon test tubes? And then a digi-block heater to warm the test tubes, and then all the required Petri dishes within the lab that is required for screening of the oocyte. And do you have a good ultrasound machine which has a transvaginal probe? We perform oocyte pickup using transvaginal probe only. So that also should be ready, and you should know what frequency the probe has. So these are what are the things that you should see for in the ultrasound machine, the frequency of the probe, so that the visualization will be better. So for a good visualization, you need to have a probe that has at least 5 to 7 megahertz, so that there is proper penetration of the signal, so that you will be able to see the area of focus, that is the ovaries and the surrounding structures, especially where there are vessels, especially the iliac vessels, are clearly visualized. So therefore, you need to have a good resolution probe. Then what the length of the probe should be about 40 centimeters, and it should be easy to handle during scanning and puncture of the follicle, or during the procedure. It should be easy to handle by you. And the shape should be easy to put in a sterile cover over it, so that most of the probes have a similar shape, so that shouldn't be a problem. Then here you're seeing this metal tips. Can you see these? These are called the needle guides. Okay, that will be specific to the probe. These needle guides get fixed onto the probe here. Here we'll be fixing it, and the OPU needle will be passed through. Can you see the hole here? Through this will be passing the OPU needle. If you don't put the needle guide, you cannot pass the needle along the probe, just like that. You will be puncturing randomly without knowing what it is. So needle guide is very important. So this is another instrument which will be fixed. Can you see all these have a screw here? So with this, it will get fixed onto the probe over here. So these probes will have a groove. So on that groove, these needle guides will be placed and they will be tightened. Most importantly, before starting the procedure, you should see whether the needle guide is tightly placed. Check for the screw once and then insert the probe. Because what happens if it is not properly tightened, and when you're doing the procedure, if it comes out, then you'll end up puncturing the surrounding structures, which can be very dangerous. So therefore, this is, you need to check all these things prior to the procedure itself. So then comes the probe covers. All these probes will be covered by sterile covers. The best probe which is available is polyethylene covers, which will be placed onto the probe. If that is not available, then you can go for latex condoms, which are non-embryo toxic. Again, best would be if you can get a proper sterile probe covers than using condoms. And these should be used non-lubricated, non-medicated, and probe covers are recommended as to prevent infection, and also to have a high level of disinfection if needed. Then coming to the digi blocker or the heating block, you would have seen this instrument in the OT. So here, can you see the digital monitor here? This will show what is the temperature at which it is set. So this will be switched on a few minutes before the OPU procedure so that this 37 degrees maintained. So into these, you can see these columns over here. So these are the location, the points where we place the test tubes, the Falcon test tubes, which will be used to aspirate where the aspirated fluid gets collected. That will be placed inside that. So the test tubes are warmed at 37 degrees. So you need to maintain the temperature during the entire course of the procedure at 37 degrees. So that is why the test tubes are placed here. So this should be switched on and maintained at 37 degrees. These are made of anodized aluminum block, and they contain blocks of, these are all for 15 ml test tubes. The last one, smaller ones, are for 5 ml test tubes to control and maintain the temperature at 37 degrees, to hold the test tubes of the follicular fluid during aspiration and warming fluids and thawing. These are the other uses in the lab. So during procedure, it is used to keep the follicular fluid at 37 degrees where the test tubes are placed. Now coming to the oocyte retrieval needle. So what is the purpose of this? Is intended for flushing and aspiration of the oocytes during the procedure. And what is it made of? That is most important. It is made of stainless, surgical grade stainless steel. It contains a tip and a body. It has a very length of 30 to 40 centimeters, depending on the brand that you use. Most of them are around 35 centimeters long. They're attached with the tubing. I'll show you the picture so that you'll know what it means. Attached with tubing for aspiration and a silicone rubber cork. It has a blunt cannula provided with single lumen for flushing. And all these things should be quality, means they should be tested whether it is safe to handle gametes. For that, they do a quality control check using mouse embryo assays, where the oocytes will be retrieved and say that the culture, everything is fine, so that these instruments can be safely used on human gametes. So this is very important. The cost of it varies on the brand that is you're using. You get it between 2,500 to 3,500 plus taxes. These are the cost of the oocyte retrieval needles. Most of the time, it can be used as a single use and throw. So again, the needles are further classified. It is not just one size that is available. The varied size, depending on the length, function, brand, size, it can be classified as different needles. The ones which are most commonly used, either the single lumen needle or the double lumen needle. Single lumen with flush, where it comes with another cannula attached, that can be used but not commonly used because it is more traumatic. And one more is quasi double lumen, that is also not commonly used. What we commonly use is, one is a single lumen and the double lumen, which comes with a flush inside. So these are the parts of the needle which I told you previously. This is the needle length, which is made of stainless steel. Here is the tip of the needle. Here is the handle of the needle. You can see here. Number 1 represents the needle length that starts from here till here. Then you have the aspiration tubing, which gets connected to the a silicone plug. So this is where this enters the ovary. From here, the aspirated fluid will come into the tubing, and from here, this gets fitted onto the test tube. From here, it enters the test tube. Then there you have another connection tubing, which is called lure connector, which gets connected to the suction apparatus. So from here, the suction pressure is maintained. Because of that suction pressure, the fluid gets aspirated into the test tube. And this is a tip. Most importantly, you should know about the tip. These are all beveled tips, which makes it easy to puncture the structures in its way. And these tips have got certain markings on them. These are called the embossed markings, and these are laser markings. These helps in making it more echogenic. So this helped, because of these markings, the needle tip is clearly visualized during the procedure. It is very important. If we are not seeing the needle tip during the procedure, we should never advance the needle, because you don't know what structures you're puncturing. So because these markings will make it very easy to make out visualize during the procedure, where it is more echogenic. It is seen on the ultrasound very clearly. So what is the difference with the double lumen or the flushing thing? The needle that you can see here has got 2 lumen, hence it is called the double lumen. One is for aspiration, one is for flushing. The flushing one has an extra tube here. The lumen which has got flushing gets connected to the extra tube through which you can flush fluid, so that the flushing will be possible. You can flush the entire follicular fluid. So the idea of doing it is, especially when you are expecting less than 5 oocytes to be retrieved. In such cases, when you do flushing, because of the shearing force, the cumulus complex gets detached. so that the aspiration, the retrieval rate can be increased, but it has got no value when the number of follicles are more than 5. Mainly used when we are expecting less number of follicles or in case of poor responders, less than 5. So only difference here is you have this extra tubing for flushing, where you can flush the fluid from here. Then you aspirate from the other lumen, which is there here, that gets aspirated into the test tube. So these are the markings which I told. These are the embossed marking. These are the dual laser markings. This is how it actually appears on the needle. Now, when you come for observation, you can check the needle for these markings, which will make it. This is because of this, it has got excellent ultrasound visibility. So there are different types of marking, as I told. One is the dual laser marking, these 2 lines, or the embossed marking, these dotted lines. The laser edge markings on the tip makes it a stable and excellent visualization during ultrasound. So seen in the initial first 2 centimeter of all the needles. So the needle tip is always beveled so that there is easy puncturing of the follicles. In that bevel tip also, there is 2 types. One is called the A type and the B type. One is the back cut bevel, or we have the lancet bevel. Most of the common ones that are used are lancet bevels. Yeah. The needle, what are the important things, why we are stressing so much on the needle tip? The needle tip is especially treated to enhance the echogenicity and shows up a bright spot on the monitor. As I told you, because of that, those markings that is there on the needle tip, it makes it visualization very easy on the ultrasound. During the procedure, it should follow the indicator line. So there are 3 dotted lines that we see on the ultrasound. Those who have done the observership, they are aware of it. There are 3 dotted lines on the ultrasound monitor where we know the line of entry of the needle. So that is what the indicator line means. So the needle will go in that direction only. So we need to focus the follicle into that direction. So because of this echogenetic, we'll know which direction it is going to take. When a lot of lateral tension is exerted on the needle, it may bend and the needle tip may leave a path on the indicator line. So whenever we are moving the probe, so when you move from one follicle to the other follicle during aspiration, too much of lateral tension, too much of movement should be avoided, because that can cause injury and also can leave a mark and lead to bleeding. In the intraovarian bleeding can happen. So in case you see that the needle has got bent because of too much pressure, then withdraw the needle, correct the curvature manually, and then you can reinsert it. Indicator line on the imaging screen should coincide with the path of the aspirating needle to ensure safety of the procedure. So that's what I said, because of too much of pressure or too much laterally if you're moving and there's no space, if the needle gets bent, you may not sometimes visualize the needle entering along the dotted lines. It might move, leave the track. So that time remove, make it straight and enter along the line of entry. The needle tip during the aspiration should, can you see in the picture here? This is the ovarian cortex. So from here you enter the follicle, and make sure the needle tip is always placed at the center of the follicle, not at the wall or the edges. What happens in that case? The surrounding walls might come and get stuck onto the needle tip, and aspiration might become difficult. Or you might end up not aspirating the follicle, or incomplete aspiration might take place. So always keep it at the center of the follicle. And once you switch on the pressure, then the fluid gets aspirated onto it and the walls will start collapsing onto the needle. So the needle tip should be kept at the center of the follicle. Contact between it and the inside of the follicle wall is avoided until the follicle is completely empty. This reduces the trauma and possible bleeding and blood in the aspirate. So if you keep it at one edge, one is the aspiration might be difficult because wall will get stuck onto it. Second thing, because of the suction pressure, there might be more trauma to the vessels are present along the wall of the follicle. So trauma will happen and the bleeding chances will be more. So therefore, you should always keep the tip at the center of the follicle. Coming to the size of the needle, needles are available in wide variety of outer diameters, that is of course measured by gauges. Smaller gauge indicates large bore needles, so the larger diameter ones, and the inner diameter depends on both the gauge and the wall thickness. The needle gauge decides the flow rate, pain, bleeding, duration of the procedure, all these things. So if you go for a wider, if you go for a lower gauge needles, then those needles are more wider. So because of that, pain, bleeding chances are high. Duration of procedure might increase, and also, I mean, not the duration of procedure, the flow rate gets affected, turbulence gets affected. Because of that, the oocyte, there might be disruption of the COCs itself. So therefore, deciding a proper gauge. Generally, what is used for oocyte pickup are 17 gauge needles is what is used for a normal oocyte pickup. So usage of appropriate gauge depends on the clinician choice as well as the diameter of the follicle. For a good mature follicle, a 17 gauge needle is sufficient. So what is the optimum flow rate? Optimum turbulence can be achieved either by increasing the flow rate or flushing of the follicle, just optimizing the number of oocytes that is retrieved. So the rate of flow depends on this law, which is called the Poisson's law, that tells like more the diameter, slower the rate. Smaller the diameter, faster the rate. So if you want to keep a study, you need to maintain steady flow. You need to maintain a constant suction as well. So differential height between the needle tip and the collection test. What depends, the law is based on 3 points. One is the differential height of the means the needle tip. Obviously, the place where the collection test tubes are placed are slightly at a lower level compared to the table height, the OT table height. Then the inner diameter of the needle, what gauge that we are taking, and the total length of the system and the vacuum pressure. What is the length of the tubing that is there, and also the pressure that is used. The minimum, for a mature follicle, the pressure that will be used is between 100 to 120 millimeters of mercury. That is optimum. So the ideal gauge of the needle should be 17, and the optimum pressure should be between 100 to 120. Ideally would be 110 to 120 would be sufficient. So what happens if the pressure is more? If the pressure is more, then the cumulus cells that is present around the follicles might get disrupted, and also it might cause disruption of the entire oocyte itself. If it is low, then you might not aspirate the follicle itself. So therefore, having an optimum pressure is very, very important. So this is how it is calculated, the difference in pressure and the radius with this law. After calculating all these things, it has been said 17 gauge with 110 or 120 millimeters of mercury pressure would be ideal. What do you call the optimum recovery rate? To achieve this optimum flow rate, so what is an optimum flow rate? When 20 to 25 ml of fluid gets aspirated per minute, that means that the flow rate is sufficient. So a flow rate of 20 to 25 ml per minute equates to 24 to 30 seconds to aspirate 10 ml of water. So aspiration time for each 20 mm follicle, according to this, if we go, should be somewhere between 8 to 10 seconds to create sufficient turbulence to optimize the oocyte retrieval. So to have a good recovery rate, suppose if everything is fine, still you're not able to aspirate, that might be because either you're having an insufficient pressure or you're not using a right gauge needle. Because if these two things are not proper, then you won't get a proper flow rate. If proper flow rate or proper turbulence is not created inside the follicle, then obviously aspiration will not take place. So all these things are decided by the type of needle that you choose and the amount of pressure that you're going to apply onto the follicle. So therefore, right needle selection is very important so that you achieve an optimum flow rate that is between 20 to 25 ml per minute. So longer the needle, or the longer the needle, the greater the vacuum that is required to maintain the same velocity. And most importantly, the flow rate should be constant during the entire procedure. So therefore, to have the same velocity, and the greater the risk of damaging the oocyte. So therefore, the ideal, too long needles are also not safe. Smaller needles are also not safe. As long as the inner diameter of the needle is 0.8 to 1 millimeter, the oocyte cumulus complex is unaffected, provided the aspiration pressure is maintained within 120 millimeters of mercury. That is because the size of the cumulus complex is between 120 to 160 microns. If you take a needle that is smaller than that, if you go for a 19 gauge needle, obviously it becomes smaller to it, where the aspiration might not, then the oocyte gets disrupted completely. So then you won't get the complete oocyte. So therefore, having an inner diameter of 0.8 to 1 millimeter is sufficient. What happens if there is too small a diameter, or if you go for a higher gauge needle, it is harmful to the cumulus complex. Deviating away from the puncture line, particularly if the ovary is situated high up in the pelvis, significantly prolongs the operating time. Because it is smaller, one is you need a higher pressure to aspirate to maintain the flow rate. Second thing is, because of the smaller diameter, it causes damage to the oocyte. Third thing is, because it is a smaller one, puncturing the farther follicles, which are there farther away, might be difficult. And then because it has got smaller, flow rate gets affected, and thus the duration of procedure also goes high. When the duration of procedure increases, then pain and bleeding chances also will increase. So these are the inner diameter that is seen. The inner diameter for a single lumen is 1.2, for a double lumen is 0.8. So this is the relation between the internal diameter and the velocity. As the internal diameter increases, so the internal diameter increases, the velocity of the flow also increases. Between the needle length and the velocity, so when the needle length increases, the velocity will reduce. Therefore, it shouldn't be too long, it should be too short. The ideal length, that is about 30 to 40 centimeter is ideal, 35 would be best. Coming to the flushing, flushing is a procedure that is intended to create turbulence and facilitate dislodgement of the oocyte from the follicle wall. So as I told you, when you flush fluid and then aspirate, because of that, the turbulence creates within the follicle. If there is any oocyte that is not dislodged from the follicular wall, because of that, the shearing force takes place and gets dislodged, and aspiration will be possible. So how much you inject into each follicle depends on the volume of the follicle. So the size of the follicle. For a mature, which is 18 to 20 mm follicle, a 2 ml fluid would be sufficient. To prevent rupture of the follicle, it should not exceed the volume of the aspirated fluid. So if you flush, say you are flushing a smaller follicle, which is about 13 mm or 14 mm follicle with a 2 ml fluid, where the follicle is not expanded so much, then it might lead to the rupture and bleeding chances will be more. So therefore, your aspiration of the flushing fluid should be equal to the amount that is aspirated. But one major disadvantage of this is it prolongs the procedure, because it is not just aspiration, flushing and aspirating. Thus, the duration of the procedure gets prolonged. Then it increases the patient discomfort and raises the cost of the cycle. The cost of the flushing needle, one is how the cost of the cycle increases. One is the needle itself is costlier compared to the single lumen. Second thing is it increases because it is duration of the procedure is more and it is slightly thicker than that of the single lumen. Bleeding chances are more, pain to the patient is more, cost of the cycle is more. So whenever we choose to use a double lumen, we should always see whether it is beneficial to the patient, because these are the drawbacks of using a double lumen flushing needle. So therefore, only those who have less than 5 follicles, less or 3 follicles, only in such cases double lumen is thought to be used. This is the follicular volume, as I told you. For a for 18 to 20 mm, around 2 ml fluid would be sufficient. For something that is around 15, 14, 1.5 ml should be sufficient on an ideal. The principle of this double lumen is constant infusion of oocyte collection media. Second thing, with what we flush the follicle, whether we flush with media, or there are two things that you can use. Either you can use media, that is MOPS or HIPPIES media, or you can go with the RL, which is again warmed at 37 degrees Celsius. If you're using media, the cost, again, media cost, definitely it is costly, therefore the cost of the cycle will increase. RL, it is cheaper, it can still be used as a cheaper alternative to media. So, but before using a ringer lactate solution, you should make sure that the ringer lactate is warmed at 37 degrees. So you cannot just bring something at room temperature and use it for flushing. Definitely that will derange the oocytes. So it should be warmed at 37, whether you're using HIPPIES or MOPS media or the ringer lactate solution. So the constant infusion of oocyte fluid media, or RL, whatever, into the follicle at the same time as follicular fluid is being removed increases the turbulence within the follicle. And this helps in dislodging the oocyte cumulus complex and increases chance of oocyte collection, which I told you before. So this is how the needle cross section looks like. I told you previously the needle, there's another part which gets connected into the flushing tubing. So here you can see this is the lumen. Then in that there are two parts. One part, this is used for aspiration. This, the smaller one, is used for flushing. There is no connection between the two. Definitely there's no connection. The entire tubing, if you cut the needle of the double lumen, this is how it will look like. Into this lumen, the aspirated fluid goes. From this lumen, the flushing takes place. Looks like a needle within a needle. Yes. The inner bigger hole.
Diameter of double lumen is also
0.8.
17 gauge.
Yes, it will come to 17 gauge only. Yes.
Thank you.
Yeah. The inner bigger hole is used to aspirate the oocyte, and the outer smaller one is used to rinse or flush the follicle. Rinse can be aspirated out again to catch the oocyte, as it was. If you have missed the first, then because of flushing, it gets aspirated. Advantage. What are the advantages of using double lumen? fluid. The dead space volume of the needle and its tubing is approximately 1 ml, and the oocyte may thus move back and forward within this dead space during the aspiration and flushing. So the design of the double lumen eliminates this problem since the aspirating channel and the flushing channel are separate, ensuring a unidirectional flow of the aspirating channel. I mean to say, so to avoid this, most of the time what we do, we always aspirate some amount of fluid prior to inserting the needle. So one is this will help us in checking the pressure and also to overcome the dead space. So there is this fluid which is there. So when you start aspirating, the entire follicular fluid will come into it. So that 1 ml of dead space won't be there. And because of in double lumen, you're already flushing and aspirating, the dead space will be covered by the flushing fluid itself. Coming to the curating the follicle, is it always necessary? What does the evidence say? Both I'm going to tell you. What is this curating the follicle? If you can see in this picture, yeah. Sorry, yeah. Here, can you see here? Yeah. So once you enter, suppose the follicular, you aspirate this fluid and this cumulus complex has not got dislodged, it's not come. That time what we do, we just gently, when we are holding the needle in our hand on the right hand, we can rotate it. So when you're rotating, you're curating the follicular walls. So instead of keeping it steady, at the end, you don't rotate it from the beginning. At the end, when the walls are going to come onto it, you start rotating it so that the wall doesn't get stuck onto it and complete emptying of the follicle takes place. Rotating the needle around the longitudinal axis may help drain small pockets of the follicular fluid, but the movement of the tip within the follicle might damage the oocyte. Yes, because you are scraping the follicular wall there. So damage occurs as the oocyte is scraped from the follicular wall by the edge of the needle, particularly in smaller follicles or in the collapsed follicle. So only in cases where you feel that it is becoming incomplete emptying or proper emptying is not happening, then you start rotating the needle at the end of the aspiration. Otherwise, routinely it is not recommended. Even the evidence say routine usage of curatage, will it increase the retrieval rate? No, there's no difference. Cumulus oocyte count. Yes, sir.
Curettage increases the chances of needle blockage?
No, it won't increase the chances of needle blockage. No. But yes, suppose if you go on curating where it is completely aspirated and you go on curating, then you'll end up aspirating the surrounding ovarian tissue also. That time it can get blocked. So once the follicle is completely collapsed and you don't see anything aspirated from it, then immediately you have to stop the suction pressure, stop curating. Okay, I hope I've cleared your point.
Thank you, ma'am. Thank you.
Yeah, yes, sir. The cumulus oocyte complex is frequently aspirated when the follicle is almost completely collapsed. Yes, this underlines the importance of aspirating the complete content of the follicle. So always you should make sure whenever you're aspirating the follicle, there should be no fluid that is left inside it. So if you incomplete emptying, where you're not emptying it completely, then you might not aspirate the follicle itself. That is aspirate the oocyte. So because most of the time what happens at the end of this, not at like once you enter immediately, you're not going to aspirate the oocyte. That the last amount of fluid what you aspirate is what is going to contain the oocyte. So therefore, complete aspiration is very, very important. Follicle curating at the time of oocyte retrieval increases the oocyte yield. This was a study that was published in Assisted Reproductive Journal in 2009. The study demonstrated that follicle curating significantly increased the oocyte yield, while it did not increase the live birth rate or increase the this increase did not lead to any increased number of embryos for selection at the time of transfer or increased number of embryos for cryopreservation. Ultimately, it did not give any increased number of embryos that is available. So therefore, you can use only when it is necessary. So these are the different brands that is available in market of oocyte aspiration needle. One is from Gynetics, Femed, Wallace, Cooks. What is most commonly used are the Cooks ones. And we choose to use a 35 centimeter long needle. And it is 17 gauge needle that is used. 16 gauge, as I said, might become smaller. Might become more wider and chances of bleeding will be more with 16. 18, 19, definitely no because it might damage the oocyte itself. And the tip, how the tip is made echogenic, that depends from company to company. So most of the company uses embossed ones. Gynetics uses even the laser markings. Wallace uses the crisscross markings on the tip. These are different diameter markings of the outer and the inner diameter. The handle where we hold the needle, the handle, some are made transparent, some are made of steel. Cook's one is made of transparent and it is color coded. What we use is a red color one. Aspiration lining, the length of the lining, the aspiration tubing length, that is 60, 75, 90 centimeters are available. Flushing, 70 and 100 centimeters are available. So this is what I said. These are the embossed markings for the gynetics. The same thing has been told. And sterilization of gynetics marking is done through gamma irradiation. This is important that you should know how the needles are sterilized and how they're checked for embryo competency. For competence to know whether they are not gonotoxic, it should be done. Mouse embryo assays are done. And for sterilization, gamma irradiations are done. This is how the double lumen, I told you now. So from here, the aspiration takes place. Here, there's another lumen here, that black marking. So from there, the flushing takes place. So the outer diameter of the double lumen is about 1.5. The inner diameter comes to 1 millimeter. 1 millimeter to 0.8 millimeter. Hooks, which are most commonly used. As I said, they are color coded based on the gauge. What we use the red color, that is the 17 gauge needle. The length of the needle is around 35 centimeters. The outer diameter is 1.5 and the inner diameter is around 1 millimeter. The length of the aspiration tubing varies between 60 to 90 centimeters. They are bevel needles. This is the double lumen. In this, you can make out very clearly the lumen that is used for flushing. This is for aspiration. Then what is the difference in that? The flushing length. The line length is about 100 centimeters. Aspiration line length is 75 centimeters. Needle length is 35 centimeters. The aspiration tubing, if you include everything, it will come to 75 centimeters. This is the same thing in valleys. And these are the swim needles. This was a study comparing the experience between a newly designed needle with a thin tip and a standard needle for oocyte aspiration. The result showed that the overall pain during the oocyte retrieval was significantly lower in the new group than in the standard needle group. But significantly more patients had less than expected vaginal bleeding with the RN group compared to the SN group, but there was no differences in terms of true needles with regard to the additional, with whether it is analgesia that is required, aspiration time, oocyte recovery time, fertilization, cleavage rate, embryo quality, number of embryos that is available did not make a difference. The effect of needle diameter on the duration of oocyte collection procedure. This was a review that was written where they showed that a constant driving pressure, the flow rate of the liquid through the capillary tube is directly proportional to the 1/4 of the radius of the tube and inversely proportional to the length and the viscosity of the tubing. So therefore, the collection time to be different between, there will be difference between two needles and the depending on the diameters that is used, which may differ by 40%. Meaning for a smaller diameter needles, the duration of the procedure might increase by 40%. For wider diameter needle, it might reduce by 40% because of the fast aspiration. As the diameter increases, the flow rate becomes more smoother. For a thinner diameter, the flow rate will be low. This is the tubing that is used for suction pressure. What is the material that the tubing is made of? Is a Teflon tubing. Between the needle and the collection test tube should be minimal to avoid unnecessary coiling of the oocytes. These are the translucent tubes, has the same size of the needle for safe oocyte retrieval. The hydrophobic filter lines present on the tubings connected to the pump prevent contamination of the unit. Length of these aspiration needles are about 62 tubings are 60 to 90 and 100 centimeters in double lumen. That is what tubings they're talking about is, I'll show you. This tubing length, this one. This is made up of Teflon material. Okay, this is definitely not embryotoxic or gametotoxic, that has been confirmed. And then the length of it will be about 60 to 90 centimeters in a single lumen. Now coming to the other part of the needle, that is the handle where we hold the needle. This one. Some are made of steel, some are made of plastic. Some, in case of cooks, it is made of this thing. It's transparent and it is color coded. It is red in color. So it is ergonomic handle, which makes it feasible to hold where you have a small groove to hold it. It can be either Y-shaped or U-shaped. And these are the different brands have different shapes. Single lumen is supplied. This one, if you want to do flushing with the single lumen itself, then you can use this blunt cannula for flushing of the follicle. Not advisable, better to go with a double lumen than using this cannula because this can be more traumatic. These are the broad differences between the single lumen and double lumen. Firstly, in whom do we use? Single lumen is used in case of normal responders or hyper responders. Double lumen, as I said, only when less number of follicles, that is seen in case of poor responders. Single lumen, yes, it is technically easier. Double lumen, it is difficult because the needle is slightly increased size. The duration is more, bleeding chances are more, pain to the patient is more, and also you need to flush and aspirate. So technically it becomes difficult. Cost-wise, single lumen is cheaper when compared to double lumen. Then more. I'm sorry, there's some mistakes here. I think it has got swapped. I'll correct this and then upload it in the LMS. Less punctures are seen with less single lumen, more punctures with double lumen, less bleeding with single, more bleeding with single. From here, it has got swapped. I'm sorry about this. Larger diameter aspiration is available here, smaller diameter aspiration because only 0.8 here, it is 1 millimeter. Here, more turbulence is created during aspiration itself. Here, turbulence is created by flushing. This is faster and slower because it is more. The inner diameter vary between 1 to 1.2. Here, the inner diameter is 0.8. This is another type of needle which is called the Steiner needle, where the flushing can be provided through these holes. Can you see here? From here, the flushing takes place into the fluid. Show you the picture here. Yeah, can you see here? This is for double. This is how the double lumen looks like. This is for aspiration. This below one is for flushing. In case of Steno, the quasi double lumen that I said, they have got holes here from where the fluid will enter into the tube. Then one more set of needle which is entirely different is the IVM needle, which are used for in vitro maturations. So the IVM needle is entirely different from what we use for our routine oocyte pickup. Can you see here? It has got two parts entirely. This is a cannula which is used to fix the ovary. In IVM, the oocyte pickup is performed when the follicles reach about 12 millimeter itself. So when the follicles are so small, the mobility of the ovary will be too high. So how do we do the aspiration is, we need to pass the needle, this needle gets passed into the ovary. Then this cannula will fix the ovary, this one. And with this, you will go on puncturing the multiple follicles that is there and then aspirate the follicular fluid. So IVM needle is used to aspirate oocytes from smaller ovarian follicles, immature ovum aspiration. So they are 17 gauge, 30 centimeter long to use the immobilize the ovary, adding rigidity to the 20 gauge, 35 centimeter aspiration needle. So this 17 gauge one is used to fix, this is the cannula outside one that will fix the ovary. That is 30 centimeter long. Then you have the inner one, which is 20 gauge, a smaller diameter to aspirate smaller oocytes. Those oocytes are much smaller in size because they are about 12-13 mm only. So therefore, with this you will be aspirating. So the gauge of this is 20. What is used to fix the ovary? That one is 17 gauge. What you aspirate is 20 gauge needle. The complete aspiration tubing length from here till what enters the follicular fluid comes to 60 centimeters. The pressure, because you're using a smaller needle bore, a smaller diameter one needle, so definitely you will require a higher pressure to aspirate the fluid. So in that, because you're using a smaller diameter one, you need to go with a higher pressure, that is 180. If you're doing a normal mature follicle aspiration, in that case, the aspiration pressure of 110 to 120 is sufficient, and the needle the needle size will be 17 gauge. Aspiration of immature oocytes, a 17 gauge double lumen needle and decreased aspiration pressure of 55 is used. Each follicle is used to flush. If you're using a double lumen one, then yes, flush 2-3 times. Mechanical curettage can also be done. A smaller gauge needle like 20 can be used with higher aspiration pressure. If you're using a 17 gauge one, then you will have to go with a 55 millimeter. You reduce the pressure. So why you are doing this? When you increase the size of the needle, then you need to reduce the pressure so that you maintain a constant flow rate. Then when you reduce the inner diameter of the needle, you increase the pressures again to maintain a good proper pressure is maintained for aspiration. For a 20 gauge, it is 180. For a 17 gauge, it is 55 for IVM. If you're using a 17 gauge for a mature follicle, then it is 120, 110 to 120. This is the aspiration unit or the suction unit that is there, where we preset the suction pressure, what we want. And through this, the tubing will be connected, which gets connected onto the cork, which fits to the test tube. Cook aspiration unit, it has got low flow regulated vacuum, which can create vacuum somewhere between 10 to 500. But what we require is around 100 to 120. The advantage of this, I mean, the suction apparatus maintains a constant vacuum accurately for long periods. The vacuum adjusts touchpad to select the vacuum. Standby touchpad is available. Then it has got an LED display. Maximum pressure is 500, which is again not required for us. And it has a foot pedal, which will be controlled by the surgeon. This is another craft aspiration unit. This is cheap. This is a Cook aspiration unit. These are different brands. So aspiration unit, you have Cook's one. Then there is craft ones. Cook's one cost, the only difference is cost, that is 2.75 lakhs. This costs about 1.5 lakhs. Can go up till 3 lakhs also. This can create a pressure of up to 400 millimeters of mercury. The green zone for safe pressure aspiration, that is fixed here from until 100. The overflow reservoir to accommodate excess volume of the follicular fluid. This one, in case that excess volume gets aspirated. Fluid trap prevents accidental aspiration of fluids into the vacuum unit. So these are the different types of suction apparatus that is available. Then most importantly, troubleshooting.
What is the disadvantage of denudation? Because embryologists will have to denudate the selected these ovums later on. So what is disadvantage of denudation while aspiration?
We don't denude the oocytes immediately. Firstly, we need to culture after retrieval also. At least 2 hours of incubation is required for the oocyte. Okay. Second thing is, if you denude it before, then IVF is not possibility. It is not at all possible.
Thank you. Okay. Thank you.
Yes. And only cumulus complex is required to perform an IVF. For ICSI, yes, denuded. Second thing, if it is completely denuded during the procedure itself, then it makes the oocyte very fragile. Then performing an ICSI is not possible. Sometimes it can damage the zona also surrounding it because of the pressure changes. If the zona gets damaged, then again, oocyte quality gets compromised.
Thank you very much.
Okay.
Ma'am,
yes.
oocyte may also be missed
yes.
because we can identify the oocyte by OCC complex also.
Cumulus complex, yes.
Completely.
Yes, because that shiny nature of it will be lost if it is completely denuded.
Okay, ma'am.
Yes. So how do we troubleshoot during OPU? How do we manage if there is a problem? So what is the major problem that you encounter that you're not able to aspirate the follicle? So what are the checkpoints that you need to see whenever you see that the needle is inside the follicle, but you're not aspirating the fluid? So what are things? One is you ensure that the suction pump is turned on and the pedal is functioning well. So all these things should be done. You do it prior to the procedure also. Before starting the procedure itself, you will check whether the pedal is working, whether the suction pressure is working properly, optimum pressure is reached or not, whether the flow rate is maintaining or not. All these things will be checked prior to the procedure itself. So even in between the procedure, if something like that happens, then see whether the suction pump is working properly or not. Check that all connections, the tubing between the aspiration tube and the pump are tightly connected. So this is how the suction is produced is because of the vacuum. If there is the vacuum gets if proper vacuum is not created, then you don't get proper suction. The fluid does not get aspirated. When does that happen? When there is any loose connections in between. So there's air leak happening. So therefore there is no proper suction that has been created. So what do you know? So you need to check whether the tubings are all connected properly, tightly. Next thing, you will see whether there is any cracks in the test tubes. If the test tubes are having very minute cracks, then at times it might not might go unnoticed. In such cases, everything is fine. Your tubings are fine, suction apparatus is fine, the needle tip is well within the follicle, no aspiration taking place. So then it could be because of those cracks, there is no airtight vacuum that is taking place. Because of that, you're not aspirating the fluid. Then what you do, you just change the test tube and discard that cracked test tube. Ensure that the collection tubing is not kinked or damaged. If the Teflon tubing that is there, if it gets kinked at any point, it gets twisted or some instrument has been placed on it or it gets kinked, that is when the vacuum is not created and aspiration doesn't take place. Third thing, you rotate the needle within the follicle. This is where we tell you to do the curating. So you do a little bit of curating because sometimes what happens, if follicular wall gets stuck onto the needle tip. So because it is stuck onto it, you're not able to provide a proper aspiration pressure for the rest of the follicular fluid. You just do a little curettage, then it gets released, and then the aspiration takes place. If still no suction, then remove the needle and perform a retrograde flush to clear any blockage. So I wish I had a picture to show you. But let me try to. I'll tell you what the retrograde flush means. So you suppose if any ovarian tissue or any hard cervical tissue, sometimes you've gone through the cervix, and cervical tissue gets aspirated into the needle. So in that case, it gets stuck into the in the needle itself, into the lumen of the needle. So that time what you do, remove the needle completely, remove the cork that is there, the rubber cork which is fixed onto the test tube, remove that and just flush it from the reverse direction into the needle itself. Push the flow media into the lumen itself. So then whatever is stuck into it will come out. Before reinserting the needle, recheck by aspirating some culture media, so you know the entire system is working well, and then reinsert the needle. So these are the various ways of checking or troubleshooting during the OPU. Test tube panels. You can, as I told you, you can use either the DigiBlock or you can use this test tube panels as well. Now coming to the embryo transfer catheters. This is it with the OPU needles. Do you have any doubts with respect to the OPU needles? Okay, I hope nothing is there. If nothing is there, then I'll move on to the embryo transfer catheters. So we have a wide range of catheters that is available in market. The ones that is commonly used, the ones are the Cooks and the Valleys ones. Ideal catheter. What is an ideal catheter that you choose for embryo transfer? Is the one that is soft, non-toxic, easily malleable, and it is visualized clearly on ultrasound. It should be an echogenic catheter. So these are the ones which will ease your embryo transfer procedure. So what are the ones that are available in market? So they can be classified based on whether they are rigid, soft, or intermediate. Of course, beyond doubt, it has been proven through various studies that soft catheters are less traumatic and chances of pregnancy rates are more. When you use these rigid ones, they are more traumatic, chances of injury to the endometrial tissue is more, that reduces the pregnancy rate significantly. So these are restricted to only those where difficult transfers, negotiating the catheter is not possible, or there's complete cervical stenosis. In such cases only we opt to use a rigid catheter. Otherwise, always it is a soft catheter of choice. Brand that is available, you have Valleys, Ganetics, Cooks, Lebotec. Most common ones are used are Cooks and Valleys. In case where the normal usual transfer is not possible at all, in such cases, there is something called transmyometrial transfer and transcervical transfer. For that, you have a different set of catheters that is available. The length of the catheter is 19 centimeters the outer and 23 centimeters the inner. It has a side opening and a front opening, means the tip of the inner one, whether it is open from side or front, we prefer to use a front opening one. So what does a catheter has? So the catheter has three parts: the outer sheath, obturator, inner sheath. Obturator usage is left to the clinician's choice. The outer sheath and the inner sheath are the ones that are used. So these are the different catheters. One is the outer catheter. These are different parts of the catheter. The outer catheter, a thick. So what is it made of? It has a thick hollow made of a plastic tubing. It has a bulb, a stopper, and a marking. The diameter of it from the outer part is about 2.5 centimeter. What is the use of the bulb? Bulb helps it to pass the blind endocervical crypts which are present in the cervical canal, and can. Second thing is stopper. It has, like how we have in all our, you have seen with Mirena insertion, you have a stopper there. So where you can adjust based on till when the outer catheter is, based on the cervical length, you can adjust the stopper. Markings for easy positioning of it. The cervical length where you want to stop till, so you have those markings. The obturator is used to negotiate the outer catheter only in difficult cases, otherwise it is not necessary. Inner catheter is where the embryo gets loaded onto it. So it has a soft tube with markings at the distal end of the tip. Soft to minimize the trauma. The embryologist loads the embryo into the sheath and hands it to the doctor for transfer. And it is sterilized through gamma radiations only. Yes. So you can see this is the outer catheter. So this is the stopper, which I said, depending on the cervical length. So where do we place the outer catheter? It is placed just beyond the internal os. So so you adjust this length based on the cervical catheter, cervical length, and the stopper is there. So it gets stopped. So it stops here. Then the inner catheter, which is loaded with the embryologist will hand it over to you, which you will insert into this outer catheter, which will go into the endometrial cavity, and the embryo is pushed into the cavity. So outer catheter is introduced to the cervix to stop short of the internal os under ultrasound guidance, stabilized with the help of the hypothenar eminence. Means with your hand, you're able to stabilize it. Then the embryologist brings the loaded inner catheter, which is gently introduced into the outer catheter and advanced in the mid-uterine length. That is, what is the mid-uterine point where you deposit the embryo? It is about 1 to 2 centimeters below the fundus. And the catheter is left, means after pushing, we don't bring out the catheter immediately. Wait for about 30 seconds. Rotate it so that you're breaking the pressure there. Rotate it and come out. While coming out, please make sure that the pressure on the plunger is not taken off. So you're putting the pressure constantly. Just a second. There is various techniques for embryo transfer. What is one that is safer and most commonly used as an afterload technique? The name itself will tell us what's the type of technique that it means. Afterloading meaning first we pass the outer catheter, then the loaded inner catheter is given to the clinician by the embryologist to transfer. There is something called as a direct transfer. The direct transfer where both the outer catheter and inner catheter are introduced together. Sometimes if you encounter, better not to use that. Best would be to go with an afterloading technique. It allows slow and gentle passage of catheter through the endocervix while the embryos remain within the incubator. Facilitate an atraumatic transfer while limiting the time of the embryos are exposed. Embryos in the inner sheath not exposed to the mucus in the cervix. Yes, because you're not going with the inner catheter. So you're completely clearing everything, then passing the outer catheter, then you're putting the inner catheter. So they're not exposed to the mucus at all. So this decreases the mucus contamination onto the catheter. So why it is so important to worry about the mucus is that it can adversely affect the implantation either by contaminating the cavity or by causing retention or displacement of the embryos. So therefore, there shouldn't be any mucus on the tip. So these are the various catheters. These are Valleys catheters. You have the soft catheter, intermediate ones. These are the stillet that is there to use it. So for one, you have classic, Sure Pro, Sure Ultra, Sure View. These are all based on the visualization of the tip. The inner tip has some echogenic area. So that makes its visualization more clearly on the ultrasound machine. These are the sizes that you can see. This is Valleys Short Pro. This is the outer catheter. These are the markings that they are again echogenic, which you can see. Then this is the inner tip. Here, the inner one, which goes into the end. This part goes into the endometrial cavity. So this doesn't have an echogenic tip. So based on this, you will have to analyze where you're going to deposit the embryos. Then you have the Sure View Ultra. This is very advantageous, especially in difficult transfers where visualization severely adenomyotic uterus or multiple small myomas where visualization might be difficult. They are completely echogenic inner catheters. So they contain small air bubbles along the walls, so which makes it highly echogenic. So you know air bubbles are looks like dark echogenic structures on ultrasound. So therefore makes it easily visible on ultrasound. So can you see this is the cut section of it? Sure View. Can you see all these bubbles? Because of this, it is clearly visualized during its entire extent during the transfer. This is the classification of different catheters. Sure View, same thing. It is same thing which I told you. Coming to Cook's catheter, it is again has an outer tip and an inner tip. This is what I was talking about, the bulb, a small bulb that is present in the front that will help it to pass along the cervical crypts. Easily it makes it to move along the cervical crypts. This is the stopper, which will be adjusted according to the length, cervical length. The outer one is about 19 centimeter. The inner one is around 23 centimeter long. The base of it, the catheter, fits onto a 0.1 ml, that is this one. This gets fitted into the 1 ml plastic syringe that we use to push the embryo into the, to load and to push the embryo into the cavity. So which I told you, here is the stopper and here is the bulb. It is a pre-cut guiding catheter, facilitates the catheter insertion. It is atraumatic, which eases the passage to the cervix. Microvolt technology reduces the media volume required for embryo transfer. Cervical stop is set at 4 centimeters, but it is adjustable where you can move it according to the patient's cervical length. This is with the inner. When you pass the inner catheter completely into it, this is the length that it crosses beyond the tip of the outer catheter. And here is where the embryos will be placed. Once you push, the embryos get dislodged to the endometrial cavity. This is another brand that is available, which is called the Kinetics Catheter. Kinetics Catheter also has a stopper here. You have the markings here. It has a bulb. This is the inner catheter. So once we pass this, then the inner catheter will be passed. They are soft. Then you get the soft catheters with the bulb tip also. Soft catheter without a bulb tips are also available. Prefer to use the ones with a bulb tip. Then you have the Friedman rigid catheter. This is used only in case of difficult transfers. Prefer try not to use these catheters because they are slightly traumatic. So this is made up of polyethylene open-ended catheter with an external diameter of about 1.6 centimeters. You can see that there's no bulb over here. So therefore, it is an open-ended catheter. It has a 4.5 centimeter soft distal part and 12.5 centimeter rigid. They're talking about the inner. This is the rigid part, and then there is a soft part. And then they're marked according to the distances. So what are the disadvantages of this rigid catheter? Causes bleeding, traumatic, uterine contractions, mucus might get trapped into it, leading to retained embryos. So success rate or the pregnancy rates are lesser compared to the soft catheters, and because of these reasons, they're not commonly used. These are the Levotech catheters. So they also have similar, most of them have this stopper, outer catheter has got markings. Cook's doesn't have markings on the outer catheter, it's only inner catheter markings that is present. And this is the inner catheter here. These only Cook has an echogenic part here, which makes it makes it visible during the ultrasound, whereas this Labotech ET catheters don't have an echogenic inner tip. Valley SureView has an echogenic inner tip. So the length of this is available in 3 lengths, 15, 19, 23. Depending on the UCL, you can decide which length is necessary. It is an intermediate, neither too soft nor too rigid. It can be inserted without a malleable stillet. Its unique curved stiff outer sheath with a bulb shaped spherical tip allows negotiation with difficult, in case of difficult this thing, it makes it more easier. So this is how this one, the Guardia Pro Protective Embryo Transfer Catheter designed to allow the controlled passage of embryos to the cervical mucus and blood. The outer sheath that protects the embryo through the cervix and then opens up in petals to further advance the inner catheter and gently places the embryo. Meaning this bulb which is there, once you crosses the inner, cross the cervical crypts and then the inner, the internal os, once you cross the inner catheter, that is when this bulb will open up. So it will be closed and then it opens up when you're passing the inner catheter so that it doesn't get contaminated with any mucus while entering into the cervix. These are transmyometrial catheters. They're of course very traumatic. So this transmyometrial will go through the myoma. This is done under ultrasound or TVS guidance only. Myoma, where can you see the metallic part? So to fix it, and then you pass the catheter containing the embryo through into the endometrium. The pregnancy rates are very less with these kind of catheters. These are done under anesthesia only. Loading of the embryo. I think all of you are aware of this mnemonic, that is MAMA, that is there is media, air, media, air, media. So these air columns, between the 2 air columns, the embryos are placed here. So the entire volume of this will be 5 microliters. Okay, so here you can see this is the tip, media, air, media. This media contains the what is that, embryo. So because of these 2 air columns, the entire inner tip also will be easily visualized because there are 2 air columns which are hyperechoic on ultrasound. So what we use, the inner tip here gets connected to the syringe. That is 1 ml syringe which we told. They should be non-toxic, should used for hand injection of contrast or other media, non-toxic, 2-piece syringe, and they should be tested with mouse embryo assays. Use of embryo transfer catheters made of 1 ml. They contain no rubber latex. Can you see here? Most of the syringes have a rubber latex here, but the one which we use for embryo transfer do not contain because they are embryo toxic. The other insulin syringes, preferably not to use these because they contain this rubber toxic material. That's it with the embryo transfer catheters. I hope I've covered most of it. If you people have any doubts, you can ask me or message in the group. Any doubts?
Ma'am, other than low ovarian reserve, in which condition, is there any other condition in which double lumen catheter needle can be used?
No. Only when there
No.
is when you're expecting less number of follicles, that is less than 3 or less than 5 follicles, we use double lumen. Anything more than that, there is no indication for double lumen.
While aspirating the follicle, if there is blood mixed this follicular fluid, what should
So
be
what
done?
happens? Always it will not be a blood. The follicular fluid is straw colored. It will not be blood mixed. So
Yeah.
when you're puncturing, sometimes you might notice a little blood tinge. That happens when you're puncturing the follicle. So because of there might be a little bleeding that happens from the follicular wall. Because of that, you might notice a little bleeding. But persistently, if you're aspirating blood, that means it is a refilled follicle, where you've already aspirated and the bleeding from the follicular wall has got collected into the follicle, and you're thinking it is a fresh follicle and you're still aspirating it. So then you need not aspirate such follicles.
Thank you.
Yes. Any other doubts? If nothing is there, then I'll end the class. If you have any doubts, you can post it in the group. Okay. Thank you so much. Thank you all.
Thank you, ma'am.
Thank you, ma'am.